Hello everyone, I'm Dr. Vivek Venkatramani, consultant Uro-Oncologist in Mumbai. Today I'll be discussing about the diagnosis and treatment options for urinary bladder cancer. Urinary bladder cancer generally presents with blood in the urine or hematuria. This is a symptom which should never be ignored and needs a thorough evaluation by your physician. Generally, some form of imaging like an ultrasound or a CT scan will be recommended. This will show us the presence and location if there is a bladder tumor, as well as its size and possibly depth of invasion. Today, a lot of research is going on the use of an MRI for a bladder lesion, and that may actually give us the exact depth of invasion in a much more precise fashion than the CT scan. If a bladder tumor is seen on the ultrasound or CT scan, a few further tests like a urine test, a urine cytology which detects the presence of malignant cells in the urine may also be recommended. Following this, the basic first step in almost all patients will be what is called a transurethral resection of the tumor. This is basically a biopsy. We put in a small camera or a cystoscope through the urinary passage and we resect out or cut out all the tumor that lies inside. This gives us an idea of the grade, which means the aggressiveness of the tumor, as well as its stage, which means how deep it has invaded into the bladder wall. The entire treatment of bladder cancer depends on the initial grade and stage of the tumor. Once the pathology report is obtained, we generally classify the bladder cancer as non-muscle invasive, which means it's a superficial or early stage, or muscle invasive when it has penetrated into the muscle of the bladder. The treatments for these differ completely. If indicated, at this point a PET scan or some other scan may be done to see if the cancer has spread to any other organ. In cases of non-muscle invasive bladder cancer, there are treatment options depending on the grade of the disease. In low-grade tumors, all we need to do is keep the patient on surveillance. This involves regular urine tests every 3 to 4 months for the first year, including a urine routine, urine cytology, and an ultrasound of the bladder to look for any recurrence. A cystoscopy, which is generally a small endoscopic examination of the urinary tract, is also used in surveillance at least at 3 months and then at 1 year and then annually, depending on the number of recurrences that may occur. In patients who have a superficial or non-muscle invasive cancer, but it is high grade, they are the ones who need further treatment, as these are quite likely to recur as well as progress to muscle invasion if left alone. These treatments include placement of a tiny catheter and installation of intravesical immunotherapy, which is BCG. BCG was among the first immunotherapy drugs discovered almost 35 to 40 years ago. It is put into the bladder and allows the bladder to generate an immune response and therefore reduce the risk of recurrence and progression of the tumor. This installation of BCG is done once a week for 6 weeks and then at regular intervals 3 months, 6 months and 12 months in the first year, and then if the patient tolerates it well, even at 24 and 36 months. BCG is a very effective form of intravesical therapy and is responsible for reducing the risk of recurrence and progression by almost 50%. Sometimes patients don't tolerate the BCG well and they develop certain symptoms of frequency in urination, urgency, and sometimes even fever. And in these cases, we may need alternative options like intravesical chemotherapy, where the chemotherapy agents are again instilled within the bladder. These are not as effective as BCG, but however, today newer alternatives are being discovered, and in the past 1 year, 2 new drugs have been approved by the FDA for this purpose. As this is quite a detailed topic, please watch the second part of our video for continuing education.